So this is the last talk of the day, IOL selection, whether multifocal, EDOF, premium monofocal, and how to go about it. So if the range of the vision patient wants is 33 centimeter to the infinity, that is achievable with the modern lenses. But there are certain limitations. Even any ocular condition, whether it's a dry, watery eye, corneal, vitreous, retinal, macular, any optic nerve, brain problem, anything wrong with any other system, multifocal lenses may not work well. And these patients have more photic phenomena like glare, halos, and starburst. There is a little bit of a loss of a contrast in the modern lenses, and these are little costly lenses as compared to the monofocal. And any surgeon who is putting a multifocal lens should be competent enough to explant it if patient is complaining. So you have to be expert in explant. And selection of IOL and power depends upon the financial status and the requirement of the patient. Like if the patient wants a distance vision, any refractive error more than -1 or more than +0.5, patient is not going to happy for distance vision. And for intermediate vision, we need that patient, if he is myopic by -1.25 to -1.75 diopter, equivalent to that range of vision is available, he is going to be happy. And the intermediate vision has become over a period of time more important than actually near vision, because most of the people are onto the mobile. Like once I had a patient, I asked whether your mother reads and writes. डॉक्टर कुछ पढ़ती वढ़ती नहीं है. मैंने कहा मोबाइल हाँ सारा दिन कैंडी क्रश जरूर खेलती रहती हैं. So I mean, in spite of that, there is a lot of use of mobile, whether you are educated or not. So that has become very, very important. And we need to understand that there is central part, what we call as a bullseye. This may be distance dominant, where patient wants a very good vision for distance. It may have intermediate vision, like Panoptics has got the bullseye, which is at 60 centimeter. And then some of the Indian lenses where the bullseye or the central part is for the near. So depending upon the patient's need, you need to select whether central part is whether it is primarily for distance or intermediate or near. And then if we see that, I'll take the prototype of the lens. Let's say the synergy lens gives you from infinity to 33 centimeter. That means addition is up to 3 diopter. Symphony or Vivity gives you 1.5, 1.75 diopter. That means if he is seeing perfectly all right for distance, then he can read up to 45, 50 centimeter perfectly all right in the intermediate range. And premium monofocal is around into 0.5 to 0.75 centimeter of addition. So that means if you correct it, zero emetropic patient will be able to see approximately 1 meter, 1.5 meter distance things very clearly, and monofocal has got hardly any range.
Dr.
So why?
I'm just wondering, when you're taking the next session talk or this session, your talk is on soft cataract. Your talk is in this
I thought it's a premium. Anyway, let me continue with this only. So should I switch over? No. So okay. So anyway, so the thing is that the synergy lenses, if by any chance patient becomes myopic, then his reading distance becomes very close. That means if it becomes -0.25, from 33 centimeter, he will come to 20-25 centimeter and be very, very uncomfortable. While if he becomes a little hyperopic, say 0.25 diopter, he can read up to 40 centimeter or so, but distance vision, because it has got an EDOF lens, will be still 6.6. So that means when you are using a high power lens, you cannot target myopia. You need to have a emetropia, even plus minus 0.25, either way is good. So synergy lens, I usually have to have that. While on the lenses which give you intermediate vision like Symphony and Vivity, if patient wants the absolutely distance vision clear, then we target 0 or even plus 0.12 or plus 0.17 is okay, less than 0.25. But if you want to enhance the effect for the near vision and reading, then keep the one eye around minus 0.25, the other eye minus 0.75. So you need to choose whatever lens you are choosing or what patient wants. And when we come to the premium monofocal, because it has got a high landing, that means if it is a 0.25 plus, still patient can see 6.6. So if the patient wants very good distance vision, you treat this lens like a synergy lens, and even the patient little hypermetropic, it will make no difference. But if he wants better intermediate vision and near vision, you treat this lens like Symphony and Vivity, keep one eye little minus 0.25, another eye minus 0.75. So even if there is a minus 0.25 error for distance, he will have reasonably good vision and he will be able to read for near as well. And monofocal, of course, most of the patients will be happy to having very good distance vision, but if anyhow you want to give a little bit of intermediate vision, then you will have to keep around one eye minus 0.5 and another around minus 1, minus 1.25. So another very important thing is that the depth of focus also depends upon the pupil size. You'll be surprised that many patients have got 6x vision with the monofocal because the pupil size is very small, particularly Indians who have got a brown iris have got a very small pupil. Astigmatism also gives a depth of focus, particularly if it is a vertical myopia, minus cylinder at 90 degree, it gives an excellent depth of focus. That means patient having 0.75, around minus 1 diopter of cylindrical power at 90 degree may actually can read for near and distance both. Higher order aberrations are also excellent for giving a depth of focus. So that means when we are using aspheric lenses, actually we are removing that depth of focus from the patient's eye. So they also give a very good, and some of them may have very high cone concentration and some of them have supranormal vision of 6/4 or 6/3. So even if they can see actually well for near even if they are emmetropic. So there are many reasons for them to have very good vision. We know what we want, but how to go about it, for that we need to understand the biometry. And the important thing is what formulas we are using, what is the anterior chamber depth. Anterior chamber depth is very important in that sense. When we put on an AC IOL, we need say 15 diopter, the PC IOL is around 20 diopter. So as the lens keeps on coming closer to the cornea, it is far more effective. As compared to if the anterior chamber depth is more, probably you need more power for the same, as compared to the anterior chamber depth is less. And whenever you have got any doubt, the refraction has to be taken into the consideration. And astigmatism is again whether you are going to use the multifocal or monofocal. In a monofocal lens, some amount of astigmatism will increase the depth of focus, while in a multifocal lens, the astigmatism cause loss of contrast further because of the multifocal lens is already losing some contrast, and if you do not correct the even 0.75 astigmatism, he may have a poorer vision. So all these are important in your decision making. So Barrett is my formula to go, but in my chart for the type of a lens, I will have all Barrett, SRKT, Holliday, Hoffer-Q, RB, Haggis, and then try to see what all of them are giving. Very important point to understand is that half a diopter of the IOL power change is 0.33 diopter, 2/3 of that at a respectable plane. So all the biometry, what you will see, 21 is a 0, 21.5 will be 0.33, 22 will be 0.67, 22.5 will be -1. So half a diopter translates into 0.33. It is important when you are going to take a decision. That means when I am choosing a synergy lens, my target IOL choice will be the IOL which gives around -0.10 to +0.23. I will not like to have a more minus in this case. Slightly on the plus side, I do not mind because the synergy gives excellent near vision. But when I am using Symphony, I will not like to have my target refraction of less than -0.25. That means if I add 3 onto -0.25, the IOL I will choose is which is between -0.25 to -0.58. Same way when I am using monofocal, a patient wants distance, I will take below first minus, that means this will be below -0.33 diopter, and if he wants plus intermediate, then I'll take the second minus, which will be around less than -0.67 and more than 0.25. So premium monofocal will be, if the patient has a strong desire for seeing distance, use it as like a synergy. If patient has got a strong desire to have little bit of mobile vision, then use it like Symphony and Vivity, keep them slightly on the minus side. And second eye, depending upon the experience of the first eye, you can fine tune the second eye IOL selection. So just a case scenario, this is a very simple case where all the formulas are giving 19 diopter, there is no confusion, you go and implant 19 diopter for emmetropia, and depending upon the type of lens you can make 0.5 more or less. So I use higher than the highest in cases of the AC is deep, because we know that the lens, if it is on the AC depth is around 4.05, the lens is going to far less effective as it is closer to the cornea. So all the formulas over here are giving 9, 8, 9, 8, so I will still use 9.5 in this patient. And in this case, if you see that what the different formulas are giving 12, 13, 14, AC is shallow comparatively, so I will not go for 14 because the lens may be more effective, I will go for rather 13, and the two formulas are going for the 13 diopter. So it is very, very important when you are using the premium lenses. And in this case, the anterior chamber depth is absolutely 1.74, very, very shallow. So in this case, though normally in a high power, I usually target little on the minus side. But in this case, because the anterior chamber depth is very low, so I'll rather go for 30, while some of the formulas are giving 30.5, and I had chosen around the first minus around 31. If the anterior chamber depth of the same patient was a 3 millimeter or so, I would have gone for 31. 30 little on the higher side, but the anterior chamber depth is less, I'll go for 0.5 less. So this is again, if the patient has got the same 21 diopter power, but if he is a myopic, I'll go for 21. If he is hyperopic by 1 or 2 diopter, I rather make this patient use little half a diopter more if patient is hyperopic and I'm getting emmetropic power. So the refraction has to be taken into the consideration. High myopes, again, most of the time these patients will be happy if they are having a little bit of myopia. So in this, all the formulas are given around 2.5 to 1.5 is the emmetropic power. I'll go for +4, which will give it around -0.67 or around -1. So whenever using your premium IOL, you have got to not only take whatever all the formulas into the consideration, you need to take the anterior chamber depth also into the consideration. So monofocal, as I already talked, spherical equivalent, if the patient has got astigmatism going for a monofocal, I'll target a spherical equivalent of -0.5 to -7.5 to give them good depth of focus for near. And if I'm going for multifocal or toric multifocal, if it is more than 0.75, even 0.7, I will like to correct that astigmatism so that he does not lose the contrast further. So in nutshell, that biometry reading, we take all the formulas, we take anterior chamber depth into the consideration, we take a refraction into the consideration, and we also keep astigmatism in the mind, particularly when we are using the EDOF lenses. So in summary, patients' needs, budget, psychology, profession, ocular pathology, pupil size, astigmatism, all of them play an important role. Target refraction depends upon the patient's need, the type of IOL, and whether you are using the first eye or the second eye. Biometric chart with different formulas need to be analyzed. Anterior chamber depth and refraction has to be taken into the consideration. And all of us know how to explant the lenses if the patient feels unhappy. Thank you.
Harbansh sir, I was noticing that patient who had the +30, the axial length was a manual entry. So what do you do in those patients where the cataract is opaque, and also you would not obviously get the lens thickness, you only have the AC depth, and some of these new formulas like even the Barrett's and the Hills.
IOL master actually gives a little longer length IOL master you can measure, but lens SR you cannot measure actually. So lens SR 32 millimeter is the upper limit, but IOL master goes up to 34, 35. Okay. So whenever you are not able to measure on the lens SR, I take the patient to the IOL master. And then, of course, in certain cases, you have got no choice but to do the manual.
No, I mean, like if you wanted to use something like a Synergy and you're not getting axial length on any biometer, because, there are two situations.
Synergy is not available less than 5 in any case. So, no.
No, I mean opaque cataract, sir. Like, in your patient, you had a manual entry for
so
the axial length.
There is absolutely no problem, absolutely, because all of us have got a LASIK available to us. So a few days back, nearly 6 months back, I operated a patient of VVT toric, and patient had post-op -1 spherical, -1 cylindrical. After 3 months, I corrected that eye, then operated the another eye. So if you have got if there is a total spherical equivalent is 0, then the rotation of the IOL you can correct the astigmatism. And the total spherical equivalent is more than that, that means the rotation of the IOL is not going to help. So then now you have got a choice either to explant or go for the LASIK. So if you do the explant, next time you may not be able to place the lens correctly into the bag if it is a little older, say 1 month or so, there may be some fibrosis and exact access you may not be able to get. So I rather prefer to do LASIK in these patients than going again. And some of the astigmatism may not be because of the cornea, because over here you are doing a refraction base. So maybe there is a lens tilt, whether there is a retina tilt or whatever may be the region. So once you do a LASIK procedure, you are sure what you are going to do. So in such cases where the spherical equivalent is more, then I do the LASIK procedure after 3 months. And if the spherical equivalent is nearly 0, I'll go for the implant rotation.